First of all, I would like to thank the organizing committee for inviting me. As you can see from the first slide, I work in the last couple of years, I work on subcutaneous diagnostic and monitoring devices. So subcutaneous means it goes just under the skin. Normally these are very small devices. You make a very small incision, like 1.5, 2 centimeters, normally in the left pectoral area, and you insert the monitor. Normally with 1 or 2 sutures, you close the skin again, and then the monitor is in place. And it can monitor vital functions 24 hours a day, 7 days a week, for 3 to 3.5 years continuously. So, but you don't do this procedure for every patient that has a small problem, because it is, of course, still an implantation. And so which are the patient population that we envision that could benefit from implantable monitoring devices? And we have several groups. As a company, Medtronic focuses heavily on the cardiovascular diseases. So in the first instance, the monitoring devices that we have currently on the market and that we are developing are mainly used for patients with coronary artery disease. The first group of patients that comes to mind, of course, is patients with arrhythmias. We are, the basis of Medtronic is an arrhythmia company, and so we monitor arrhythmia. We have already a 5+ year experience in diagnosing unexplained syncope. I will go a little bit more in detail on that later. Currently, we also have a device that monitors atrial fibrillation, and I will explain to you why that is so important. Then we do a lot of research on monitoring heart failure. Many people have heart failure. These are US figures. Around 5 million people in the US have heart failure. So that means also more than 5 million people in Europe have heart failure. So the market of that is enormous. And when that disease progresses, these patients are getting more and more expensive. So what you want to achieve in heart failure patients is basically really managing their disease very well. Try to keep them out of the hospital as much as possible. The third group is patients with coronary artery disease, especially cardiac ischemia. So STEMI, ST elevation myocardial infarction, is, I think, an event that if you don't treat it well, it can result in serious consequences. And then, of course, we have some more general cardiovascular risk factors, like hypertension, where we feel that monitoring could play a role, but whether that needs to be an implantable monitor, that still has to be seen. So why do we want to monitor these patients? I think that if you ask a clinician, why do you do a diagnosis? Why do you monitor a patient? I think there is basically 2 reasons for it. Monitoring should result in either it guides the physician to more detailed investigations, so he has now a clue in which direction he has to find the problem, or it has to drive therapeutic interventions, so that the physician knows, oh, now I know the problem, now I know what to do about it. And so by doing that, by driving further investigations or therapeutic interventions, you can hopefully prevent significant cardiovascular events. And I've listed some of these events that we can monitor, and we have good therapies for, but we need to provide these therapies at the right time. If we do it too late, it is too late. Like atrial fibrillation, for example, the problem of atrial fibrillation is that much of the atrial fibrillation, about 90%, 9 of the 10 atrial fibrillation events are asymptomatic. So we all can have atrial fibrillation and we don't feel it. And for many patients, a stroke is the first event. And that is a very dramatic event. So once you know that you have atrial fibrillation, you can have a very effective therapy, oral anticoagulation. It will reduce your risk of stroke by 80%. The same is true with myocardial infarction. Many people who, especially for the first time, they feel some chest pain, but they deny that they have a major problem. So they wait and wait and wait. And we know time is muscle. So if we wait too long, we get myocardial necrosis, and basically the patient goes into heart failure. And if you are in time, there are very good therapies, PCI, stents, there are very good therapies for myocardial infarction, for coronary artery occlusion. The same is true for heart failure. Heart failure events start often asymptomatic. The patient doesn't feel yet tired or short of breath, but he is accumulating fluid. And once he starts to feel it, it's often too late. Then it's a matter of normally 1 or 2 days or even hours before he ends up in the hospital and he needs to stay in the intensive care for 5 days. If you know this in advance, if you monitor the fluid accumulation in advance, there is a very effective therapy, is diuretics. And last but not least is sudden cardiac death with ventricular fibrillation. Of course, that is sudden. And the problem is that many of these patients don't have a defibrillator because they don't know that they are at risk. And so the result is the most serious. These patients will die if you don't act upon it. So hopefully we can also design monitors that can monitor ventricular fibrillation for patients at high risk. And when they have the event, that the monitor will automatically alert bystanders or caregivers so that they can start CPR or even defibrillation. The second objective of monitoring is trying to identify patients who are at high risk of major cardiovascular events. So if you have patients, for example, post-MI, they have had a myocardial infarction. If they start to have arrhythmias, that's a major risk factor. So you can leave a patient after myocardial infarction alone for quite some time, but you got to know the moment when you have to act, when you have to implant a defibrillator, for example, because they start to have arrhythmias. So risk stratification, I think, is an extremely important one, ruling out and ruling in patients for the appropriate therapy. Now, monitoring, there are many ways in monitoring patients. I think the oldest one is symptoms. And symptoms, if you do the questioning of a patient very well, many physicians are very skilled in that, and they can find the problem already by having a good interview from the patient. But I think the big shortcoming is that you only will find the symptomatic events, and many diseases start asymptomatic. If you go to equipment, there is a lot of external equipment, and we have even heard more during this morning and this afternoon's sessions. Many equipment is available where you can monitor patients, for example, for arrhythmias in this example. It goes up from 1 minute to even a month. And we feel that if you go over a month, it may not be wise anymore to use external monitoring.